Hi, thank you for having me. My name is Dan Whitney. The title of my talk is Bone Development, Fracture Risk, and Post-Fracture Consequences for Individuals with Cerebral Palsy. So I have two aims to my talk. I'm going to first introduce bone fragility for individuals with CP, and I'm going to take it from the context of abnormal structural development of muscle and bone and how that impacts bone fragility across the lifespan. Then in aim two, I'll talk about something that has garnered less attention, and that is what happens to people with CP after they fracture, documenting post-fracture health declines, and I'll highlight some emerging research that's just beginning to identify which diseases arise and when following a fracture. The ultimate goal is to inform priorities for post-fracture healthcare management and secondary prevention. So there are a wide range of functional and health complications that can impact musculoskeletal development in CP. These include things like neuromuscular dysfunction, low activity and fitness levels, altered biology, puberty, nutrition, a body composition favoring high fat, low fat free mass, and children with CP undergo many surgeries to correct musculoskeletal deformities and are exposed to a high number of concurrent medications chronically, which can increase risk for iatrogenesis. Now, for a variety of ways, these can impact muscle and bone structural development. So I wanted to highlight a few studies looking at the structural deficits of muscle and bone using in vivo imaging. Now, this study used magnetic resonance imaging. The region of interest was the middle third of the thigh, which is that red box on the skeleton. This is a representative image and axial view from a typically developing child on the bottom, a child with severe CP on top. We can see that the child with CP has a much smaller thigh. That gray inside is the muscles. We can see very underdeveloped musculature. The red circles highlighting the femur bone. That dark black ring is the cortical bone. The circle inside is the bone marrow cavity. For reference, the red circle is the same size, so you can really highlight the vast underdevelopment of the femur architecture. On average, when these groups were compared, children with severe CP, most were pre-puberty, had about a 50% deficit in muscle volume and even greater deficits of estimates of bone strength. Now, at this point in the literature, it was thought that the extent of these musculoskeletal deficits were really confined to those with severe CP non-ambulatory. So we wanted to look at some of these parameters in children with mild CP. So we looked at the middle third of the leg, representative image from a typically developing child on the bottom and a child with mild CP, GMFCS2 on top. Now, what's nice about these comparisons here is they're both boys, they're the same age, and they have the same tibia length. So this is the same spot on the tibia for ease of visual comparison. And we can see that the child with CP has less muscle and also poor muscle quality, a lot of fat within and between the muscle. That small black arrow in panel A is pointing to the tibia or the shin bone. That black ring is a cortical bone. We found significantly underdeveloped cortical bone. And we also found disproportionately thinner cortical walls in the medial and posterior aspect of the bone, suggesting asynchronous underdevelopment of the femoral or of the tibia architecture. When these groups were compared, we found that children with mild CP, all were pre-puberty, had about a 40% deficit in muscle volume and estimates of bone strength. Now, these studies were important because they highlighted the macroarchitectural deficits of bone in the middle portion of these bones where muscle's the thickest and there's a lot of muscle pull in the bone. However, children with CP and individuals with physical disabilities across the lifespan are more likely to fracture at the ends of long bones where it's more trabecular rich bone. So if we think about a long bone, the shaft is this thick cortical wall that surrounds this open bone marrow cavity. As we move to either end of the long bone, the cortical bone will thin out and that bone marrow starts to become interwoven with trabecular bone. And so at the ends of bone, it's the trabecular bone microarchitecture that helps to establish the adaptability and strength of the bone. So we wanted to look at the trabecular bone microarchitecture. We had a very focused, zoomed in region of interest at the distal femur right above the knee, and we placed the region of interest box right above the growth plate. This is a representative image from a typically developing child on the bottom and a child with severe CP on top. In this protocol, the lateral half of the distal femur was analyzed, which is that dark shaded region, and the bone marrow cavity was separated out from the surrounding thin cortical wall, and the image was binarized. So what you see in C and D, white is trabecular bone. So we can see that the child with CP not only has a smaller and a differently shaped bone, but a very low concentration of trabecular bone, thin trabecular structures that are not well connected and seemingly disorganized, potentially explaining why the distal femur is one of the most commonly fractured sites in CP. On average, we found that children with severe CP had about 30% deficits in these trabecular bone microarchitectural properties. And we found similar findings in children with mild CP in the distal femur, in distal tibia, or the ankle, but these are unpublished. Now, I purposefully did not talk about any studies looking at bone density. Bone mineral density is really important to understand bone strength, but there's more to bone than density alone. And like other fields, our field over-relies on bone density as a singular marker that describes whole bone strength. So briefly, I wanted to highlight a couple of studies that really highlight the structural aspects of bone development that are really responsible for driving bone fragility, especially across the lifespan, and yet are not picked up by these bone density measurements. Bone density refers to the extent of mineralization or hardening of the underlying bone tissue. Bone density can be modified across the lifespan, but other structural traits are less or not at all adaptable after certain stages of growth. So the bone structure that you build during growth is largely what you take with you for the rest of your life. Now, in typical bone development, this is a complex multifactorial process. This is informed by a dynamic interacting network of genetic, biologic, and environmental factors. Bone development has unique priorities at different stages of growth to form, integrate, or establish different structural parameters of the bone. Collectively, these processes harmonize to establish the permanent structural basis of the bone's framework. So abnormal bone development refers quite simply to when typical bone development goes awry. Now for CP, given the long-standing issues with motor dysfunction, progressive underdevelopment of muscle, and altered biology, there really are multiple time points which bone structure may not be developing as it should. And as I've shown in the previous studies, this is occurring even prior to puberty. So if left uncontested, this can compound, leading to unrecoverable structural deficits and permanent structural bone fragility. Now, my team and I are interested in trying to understand the different ways bones grow and can become fragile from a structural and biological perspective, because we think this will give us an opportunity to identify better ways to detect, prevent, and treat the underlying mechanisms responsible for the bone fragility. Unfortunately, these ideas are in the form of grants, which are in review, so I have no data to share. So until I get that data, to demonstrate the consequences of abnormal bone development, I'll highlight a few fracture studies. Now, the hypothesis is that fracture risk would be elevated in the pediatric years, but that the insufficiently built skeletal system would really rear its ugly head in the adult years, which would be characterized by an early and excessive burden of fractures early in the adult years. So now this first study looked at the risk of fracture among children with and without CP that were 13 years of age and younger at the start of follow-up. We looked at 5-year risk so we could capture fracture risk from 0 to 18 years old. This first graph looks at, on the y-axis is the 5-year risk, the percentage of fracture at any site. Now, what was nice about the study is the sample size was large enough, so I was able to provide estimates for each year of age, which is on the x-axis. So one way to interpret this graph, if we look at the 2-year-olds, about 10% will sustain a fracture at any site as they age from 2 to 7. So we see an effect of age, but we don't really see a separation of fracture risk between children with and without CP. However, we know that there's this preferential deficit of bone structure, especially in the lower extremities. So when we separate it out by fracture site, there's a different story. Children with CP had a higher 5-year risk of fracture at the vertebrae, hip, or lower extremities, and a lower 5-year risk of fracture at the upper extremities. Now, this is important because fractures at the vertebrae, hip, and lower extremities are more complex. They're more difficult to clinically manage, and they're associated with an array of risks and health complications. Now, what I realized a little bit too late is I did not do a very good job of transitioning from this pediatric to the next slide, which is on adults. So I wanted to narrate an important concept. So in the general population, we do see this uptick in fracture risk in the adolescent years, but then it comes right back down to the young adult years. It's very, very rare. It stays very low until about menopause for women and elderly for men, where it starts to increase. What we've shown in other studies is that for people with CP, we see this uptick in fracture risk in the adolescent years, and it just kind of stays elevated and continues to climb at an alarming rate in the adult years. So the next study doesn't visually represent that very well. So this study looked at the 5-year risk of fragility fractures among adults with CP who are 18 years of age and older. And I was able to provide estimates for these narrow age bands that you can see on the x-axis, women on the left, men on the right. And we compared these fracture profiles to elderly without CP, which is the open circles. And those red lines just mark where the elderly non-CP groups are for ease of visual representation. And really the take home here is that young women with CP and young men with CP have a similar 5-year fragility fracture risk as elderly without CP, 65 to 74. We also found that the whole cohort of adults with CP had a higher number of repeated or subsequent fragility fractures. And another interesting take home was that young adults with CP had a similar number of repeated fragility fractures as elderly without CP. So if we're looking at these fracture profiles, this suggests that these fracture burdens is occurring about 4 to 5 decades premature for individuals with CP. Now, in summary for AIM-1, for a variety of reasons, children with CP have abnormal structural development of muscle and bone. This not only increases risk of fracture at more complicated sites in the pediatric years, but it also increases risk for repeated fragility fractures that begin to accumulate early in the adult lifespan. So the next question is, what happens to people with CP after they fracture? The post-fracture disease sequela is well documented in the general elderly population. And we're now seeing that adults with CP have this early and excessive burden of fragility fracture. We also know that individuals with CP can have early onset medical complexity, and this may exacerbate post-fracture health declines, possibly in unique ways. So for the remainder of this talk, I will highlight some of our emerging work that's just beginning to identify which diseases arise and when. Again, the ultimate goal is to inform priorities for post-fracture healthcare monitoring and prevention to improve healthful aging for people with CP after they fracture. Now, we started to look at how clinical interventions modify these post-fracture disease pathways, but that didn't make it into this 25-minute talk. So for the remainder of this talk, I'm going to be presenting these studies that come from these large epidemiologic designs, different sort of statistical analyses, all these different effect sizes and numbers to derive the clinical concepts. And I know that's not everybody's cup of tea. So I took the main interpretations and I'm presenting them visually. However, I did want to talk about some fundamental methodological aspects that will help us understand where these figures are coming from and to help us with interpretations. So when I wanted to think about how to begin studying post-fracture health declines, I found that nationwide clinical data from administrative data sources was the only data source that provided the rich longitudinal information to study these concepts that also included people with CP and included ways to identify people with CP. Now, the figures that I'll present are really focused on the primary cohort of interest, adults with CP that sustain an incident fragility fracture. So the start of follow-up is from their date of fracture. But all of the interpretations come from this dual comparison cohort design compared to adults with CP without a fracture in a recent time period and adults without CP with an incident fragility fracture. Now, confounding in all these studies was accounted for using various statistical and inference-based techniques and generally included demographics, health services, and several indicators of medical complexity. Now, claims data does not contain information about the severity of CP. However, this is associated with medical complexity, which is accounted for. So it's a reasonable proxy. So it's as if we have the GMFCS and adjusted for it rather than stratified by it, which is what we would typically do in the field. Now, we want to come out hot, so we decided to look at high burden outcomes that were really relevant and important to aging with CP, and this included mortality, cardiovascular disease, and respiratory disease. The benefits of this methodology is there's a really large sample size. So for this early work, we were able to provide relatively precise effect estimates. For example, the primary cohort that I'll present had sample sizes ranging from 1,000 to 4,000, and the comparison cohorts had anywhere from 9,000 to over 300,000. This also allowed for additional analyses to derive clinically meaningful information, which I'll explain here. So what we found is that when adults with CP sustain an incident fragility fracture, they have a high rate of mortality, especially in the short term, and the effects remain up until 2 years of follow-up. Now, the effects may extend beyond this period. We just haven't looked past 2 years yet. We also see that fractures are associated with an increased incidence of cardiovascular diseases and respiratory diseases. Now, through a variety of secondary analyses, we found that all of these findings were present for men and women with CP across the lifespan, with the take home here being that these post-fracture health declines are occurring prior to entering the elderly years and regardless of the fracture site. Now, these studies were important because they helped to establish a robust association between fragility fractures and health declines. It also formed the basis to begin studying the pathways linking fractures to these health declines. So to begin studying these pathways, I performed an exploratory mediation analysis where I tested for the mediating effect of each of those incident cardiorespiratory diseases on the association between fragility fractures and mortality. Now, mediation analysis in this context could help us explain why people with CP that fracture have excess mortality. So for example, perhaps a fracture leads to a particular disease, and that disease is responsible for the excess mortality. So there's a lot of interesting findings, but the main takeaway was that pneumonia had the strongest mediating effect. Now, this is important because pneumonia is one of the leading causes of death for people with CP. However, it's an acute condition that can arise shortly after major physiologic stressors like fractures. And this in turn can lead to pathophysiologic decline, especially of the cardiorespiratory systems, leading to mortality. So we modeled up to 2 years of follow-up, which likely underestimated the short, acute, and consequential nature of pneumonia following a fracture. So now this is a exploratory study, so there's not a lot of inferences that really should be drawn from this, but this pointed us in the right direction to go where to go next. And that was to better understand the risk of post-fracture pneumonia and its effect on health and survival for adults with CP. This is the last study I'll present, and there was 2 objectives. The first was to characterize the risk patterns of pneumonia within 30 days following the fracture, and then to test if post-fracture pneumonia increased the risk of mortality and cardiovascular events. So now what we're looking at here is the cumulative incidence of pneumonia on the y-axis, where 0.09 represents 9% of that cohort, over the course of 30 days following the fracture, where 30 days is on the x-axis, day 0 corresponds to the day of the fracture. Now I first plotted the one of the comparison cohorts, the general population without CP that sustained a fracture, and I stratified them by these age groups: young, middle-aged, and elderly. And as expected and consistent with the past 4 or 5 decades of research, it's elderly that when they sustain a fracture, they have this high early rate of pneumonia, but pneumonia is not really a problem after fracture for young or middle-aged people. Here are the plots for adults with CP. We see there's really not much separation between the age groups, and they're all much higher than elderly without CP. And when we compared the rates to the corresponding age group, we found that adults with CP had about a 2 to 16-fold higher rate of post-fracture pneumonia compared to adults without CP. Now, this third group here, those dotted lines, represent one of the other comparison cohorts, adults with CP that did not sustain a fracture in a recent time period. This group was propensity score matched to the primary cohort on a number of demographic, medical complexity indicators. Theoretically, what this tells us is what these patterns would have looked like if the adults with CP did not sustain that fracture. So the differences between the solid lines and the dotted lines, between the pattern and the magnitude of pneumonia, largely represents the effect of the fracture. So the take home here is that there is a high early risk of post-fracture pneumonia for adults with CP that's present across the adult lifespan and not just in the elderly years, which deviates from the general population. Now, in the second objective, this was the primary cohort, only adults with CP that sustained a fracture. And the exposure here was those that went on to develop pneumonia within 30 days of the fracture, compared to those that did not develop pneumonia within 30 days of the fracture. Pneumonia after 30 days was not part of this study or was not looked at. We wanted to look at outcomes at 2 distinct time periods, 0 to 30 days from the fracture to capture any sort of short-term effect of the pneumonia, and then 31 to 365 days to capture any sort of sustained effect in case there was these ongoing pathological declines that individuals were able to survive in that beginning portion. What we found is that those who developed pneumonia had about a 6-fold higher rate of mortality, 6-fold higher rate of heart failure, and a near 2-fold higher rate of cerebral vascular disease within the first 30 days. And these effects remained elevated in the follow-up period. Mortality was about 3-fold higher. Heart failure and heart attack was about 2-fold higher, but there's no longer an effect for cerebral vascular disease. Now, through a variety of secondary analyses, all of these associations were present for men and women with CP across the adult lifespan. Again, the take home being that this is happening prior to the elderly years and present regardless of the fracture site. So the take home for the whole presentation is that for a variety of reasons, individuals with CP have abnormal structural development of muscles and bones. This not only increases risk of fracture in the pediatric years at more complex sites, but it also increases the risk for repeated fragility fractures that begin to accumulate early in the adult lifespan. Now, when adults with CP do sustain a fracture, they undergo these rapid health declines that seem to remain in effect up to 2 years of follow-up. And because of what we studied, these health declines generally include cardiorespiratory pathways, possibly in unique ways. So to me, this presents two areas of active research investigation in my lab. First, fracture prevention. We really need to understand the different ways bones grow and become fragile. This will allow us to identify better ways to detect, prevent, and treat the underlying mechanisms contributing to the bone fragility. And second, post-fracture prevention. We really need to understand the timing and composition of the post-fracture disease sequela, as this can inform on priorities for post-fracture healthcare management and secondary prevention. With that, I'd like to thank my funding sources that were able to provide something that made it into the slides today, my rich mentorship team for my PhD to my early career, and all collaborators with musculoskeletal health and CP. Thank you for your time.
I have a question about, are you able to tease out the impact of activity level on your people that got pneumonia?
No, yeah, claims doesn't have that information. That would be nice. Yeah.
Was there any difference, like, is this everybody with CP, or are these varying members that have CP, or are they wheelchair bound?
So the second half of the presentation, we're pulling from claims data, so we can't get at that information. However, we've pulled from private and public Medicare and Medicaid. So we're probably as everybody, but we're not able to distinguish between. But we did account for medical complexity. So again, I would say these are, in a very rough way to speculate, I would say this is maybe like a GMFCS3. So things might be a little bit worse or more severe. Things might be a little bit better for a milder.
You know,